I just want to welcome everyone here tonight. My name's Penny Ballum, and I'm the chair of the board of Vancouver Coastal. And very, very happy to have this opportunity to have another open forum for our board. I just want to start with recognizing that this meeting is taking place on the traditional homelands of the Musqueam Squamish. In a minute, I'll introduce Chief Ian Campbell, who's going to open it. But I just want to invite anybody in the back who wants to sit. There's still some seats up front. And maybe what we'll do is we'll have Chief Ian Campbell, do the opening for us and the welcome and bless our work here. And then I'll come back and, say a few opening remarks and just highlight some of the people that are here, because we have a really nice turnout from our nonprofit sector, and we're very, very happy to see both our staff and people from our community here. But right now, maybe what we'll do is invite our Squamish Chief Ian Campbell to offer a traditional welcome and just say how nice it is to see you again, Chief Campbell. We've had a few moments together over the last years, and I haven't seen you for a while. It's really nice to see you. So thank you so much for being here. It's a real honor for us to have you opening this forum.
Thanks, Penny, and it's really good to see you as well. Hi, everybody. So, my ancestral name is Khalek. Sukyo siam Kwansnas. My chieftain name is Sukyo. I'm a hereditary chief of the Squamish Nation and an elected official. Serving 20 years in politics, so I call it recreational suffering. But certainly that's where I met Penny many years ago when she was with the city, and thank you for all of your ongoing commitment and support for the Musqueam, Squamish, and Tsleil-Waututh families and us as a community here in Vancouver. It's an honor to welcome you this evening to the shared territories of our Musqueam, Squamish, Tsleil-Waututh, Akwetals, all of our families of the Coast Salish peoples. This land has sustained us for innumerable generations, and I find it very exciting that we're gathered here, that we're having this dialogue in this open house. It is very important. We're all in the same canoe, and we all must continue to support each other. As a First Nations leader, I'm lucky that I have many of my elders still alive, or many of my mentors, the elders who have passed on, that shared amazing stories of resilience and tenacity. And our families certainly experienced mass depopulation in the mid-1800s to the early 1900s with epidemics that were introduced by settlers upon arrival here in this part of the world. So that trauma, that deep-rooted sense of community and belonging continues to be something that we are putting pieces together again. So the reconciliation, the work that Vancouver Coastal Health is doing, is paramount to safety and to wellness and to moving beyond trauma. So I commend each and every one of you. I thank you for your leadership and your continued commitment to our families and to our communities. With that, I'm going to share a song, which is a top 10 of our Potlatch hits for you this evening. We are celebrating Hobiye, which is the Nishka New Year, which we had a huge celebration last weekend at the Peony Forum. With thousands of people in attendance. And coincidentally, it's also our Coast Salish New Year. As the February new moon comes out, this is what we call Tamwalchs, the time of the frog, and the frogs will be coming out of hibernation, singing their songs in the coming weeks, and that will call the herring back to our waters. Tamthaut is the March moon. So it represents that change and that rejuvenation. So let's honor that and celebrate it as we gather here tonight. So I'm going to share I suppose our Musqueam welcome song, with Itzap Misteach, which was taught to me by my late uncle Tiachthat Siam Dominic Point from Musqueam. And this song says, "You are all good people. You come from a long lineage of good people." So this would be a song that we would sing as your canoes would arrive ashore to partake in our feasting and celebrations and potlatching. So with that, welcome. Sosium. Thank you.
Thank you very much, Chief Campbell, and I hope you're welcome to stay. Being one of our residents in Vancouver Coastal, we want to make sure that we answer any questions you might have tonight. That's the purpose of this open forum. So thank you so much. It's a real honor and a privilege to have you come and open this forum for us. So thanks so much. I think our opening really underlines how critical the whole topic of reconciliation is for our health authority. It's a very big project to try and basically shift the culture of a big organization to address issues that have been with us many, many, many years, and it takes time. But I want to recognize, first of all, Chief Campbell, the learnings I had when I was working in the city, my opportunity to work with you and other chiefs of our 3 host nations. It's really through our relationships and the work we do together that we actually can best learn, how to bridge that reconciliation gap and change how we do business, how we offer services, how we think and do things. And so, we really appreciate your patience and the fact that your leaders are actually helping us do a better job. And I want to recognize Leslie Bonshore, who is the head of our Indigenous initiatives in Vancouver Coastal, and who we feel very, very lucky to have someone with her expertise, her connections, her friendships across our whole province, because I think you allow us to, move ahead in ways that, wouldn't necessarily be possible without someone who knows the community so well and can connect us in a way that allows us to advance our work. So thank you so much. I just want to, I made a little list. I went around the room before we started just to get a sense of, who we have here. This is an open forum of our board, and there's a variety of ways that we can do this work, but really the purpose of these fora is to connect with our public and also with our staff, because our staff is a big part of our public. But we really want to welcome, our colleagues from government, our community members, our nonprofit partners. We have a very long list of people we invite to these meetings, and I think our hope is that they get more and more well attended, and that they become a stronger and stronger way for us to reach out and hear from the community, and for us to exchange information about things that are happening in this really remarkable organization, and the things that you can tell us about that are worrying you or are working well for you. And it's just a way to exchange information, concerns, and just really help us do a better job. I want to just recognize that I have 2 other board members. This is a period of the year, as we all know, that lots of people seem to be away. But I really am delighted to have Howard Horowitz, who's sitting in the bleachers back there. I tried to get him to come up to the front, but we're very proud to have him on our board, and Alan Badela, who's here. And these are 2 really fabulous colleagues who are working very hard to basically help do the work of the board to provide the sort of stewardship of our organization. I think we've got a number of representatives from various organizations here tonight, Mosaic, Reach, who I saw some of you this weekend at the opening of our UPCC. We've got members from the South Vancouver Neighborhood House, Right at Home, the Native Co-workers and Counselors. We have a trainee who's here representing that organization, so we're very happy to have her. We've got representatives from HEU here who are very steadfast attendees at our open forums, which is terrific. We've got Spinal Cord Injury BC, one of our members who actually works in our organization, or works out of GF Strong anyway. And then we've got a representative from the, I'm going to get this right here, the Tona Ragumi organization in the back row. representing parts of our Japanese community. So just a sprinkling of people, and I think there are also some just general members of the public here, which we really welcome. So tonight what we've, and I forgot to mention Mike from Mike Lee's, Tyson Mike Lee's, who is one of our MLAs, is executive assistant, who's here, so welcome to you, Mike, too. This presentation is being live streamed. I told them if they told me that, I would have had my hair done. But the purpose of that is not to show us off, but actually to allow another way for people to actually track, you know, what's going on in our community and to kind of see these kinds of sessions and allow the information to be shared more broadly. The strength of social media, which is really great. I think that, you know, these are always challenging times in our world, and, you know, the health system is always a place where there's lots going on. We're going to hear tonight from Dr. Patty Daly, who's going to talk to us about something that's, you know, on everybody's radar, the coronavirus issue. There's been a lot of public information from our minister, our chief public health officer, and I really felt strongly that we should have our own chief public health officer, you know, just one step closer to our community, be here to, you know, give a presentation and, you know, answer any relevant questions, because it's one of those things that, you know, people are not sure, you know, are they feeling comfortable or are they not? But the best way to deal with that is to have access to good information and people you know and you know, have a chance to talk to figure out what, you know, what we should be thinking about and what we should be doing. What I can tell you is that our organization is working very hard to, you know, prepare for, you know, whatever it is one prepares for in these situations. And it's lots of work, and we've been talking about issues like this for many years, and we've experienced a number of, you know, similar episodes of infectious disease, and, you know, we are prepared, and I think Dr. Daly will help, you know, give all of you some comfort that things are well in hand and that we, you know, we're here to provide direction. I also want to welcome our other senior executives here, Mary Ackenhusen, who is our CEO, and Laura Case, who is our Chief Operating Officer for Vancouver Community, who's responsible for all our community-based programs and also our full continuum of mental health. And Vivian Eliopoulos, who is our Chief Operating Officer for Vancouver Acute, which is a, you know, a big part of our authority, our Richmond Hospital, our Vancouver General, and we have, you know, engaged in Vancouver Acute, obviously, is our Providence St. Paul's Hospital. So although I'm not sure we have any representatives from Providence here tonight, Vancouver Acute is really the acute care part of our Vancouver community. So a really also a really critical area of activity for us. And, you know, what we're going to do tonight is just highlight some of the things that are happening in those two parts of our sector. And also, you know, we're doing, to Chief Campbell's comments, we've done some very special work in the Vancouver acute system, particularly at VGH, on helping that very big institution, you know, really get a better understanding of, you know, what our First Nations and our Aboriginal Métis population need as they come and access our health services. And so there's been some really remarkable work done under the stewardship of Leslie and other really remarkable community members. And we just wanted to share some of that with you too, to just show you that we are really trying to move the dial on Indigenous cultural sensitivity and inclusion and safety and trauma-informed care, so that actually we're doing a better job. So I'm very happy to, you know, maybe start the formal part of the session, and I think Dr. Daly, you're up first with your update on coronavirus, and we'll come back to the other two presentations. Thanks so much.
Thank you, and thank you everyone for coming tonight. As the Chief Medical Health Officer, I give an update at each of these forums, or one of the other medical health officers does as well. And given that this is really the topic that you're all hearing about in the news, and I know that there are many questions that you may have had, your family members may have had. I thought it would be a good opportunity to provide you with some information that I think can be helpful to talk about what is this new coronavirus and how are we responding. So first of all, the new virus that's emerged, which is now called COVID-19, is a virus that's a member of a family of viruses called coronaviruses. And these are known to humans. There are common coronaviruses that circulate and cause the common cold. Probably everyone in this room has at one point or another in their lives been infected with one of those common human coronaviruses. But there are also coronaviruses that circulate in animals. And occasionally they jump from animals to people. And this has happened a couple of times that we know of in the last 20 years. You may remember SARS, which was a coronavirus that started in animals and caused an outbreak in 2003. We had several cases here in Vancouver. There was an outbreak in Toronto. I was the medical health officer who followed up all those cases, so I remember those days very well. Penny Bellin was the Deputy Minister of Health at the time. There's another a coronavirus called MERS, which arose in the Middle East and from camels and has caused some severe human disease as well. Neither of those coronaviruses were easily transmitted from person to person, and they were controlled through public health measures. Now, this new coronavirus, the first cases were identified in Wuhan, China, which is a city of about 11 million people in central China, in late December 2019. So that's really only a little over 2 months ago. There were a few cases of pneumonia that were seen in a local hospital. They weren't typical, and so some testing was done by the physicians, and within a week, really, of identifying those first cases, they had identified a new virus. They had sequenced the DNA, and this is really far advanced from the days back when we saw SARS, where it took many, many weeks to identify the virus. The Chinese officials had this identified within a few days, shared that sequencing with the world, and reported the cases to the World Health Organization. Now, the original outbreak began, you may have heard, it was linked to, there was a live animal market in Wuhan, and they did believe that there was an animal there that had been the source of infection. They hadn't yet, and they still have not yet identified what that animal was, but very quickly they realized that there was person-to-person transmission, and I'll describe a little bit later how that has progressed over the last 2 months. But we've learned a lot about the virus, especially from the officials from China, who've published a lot of good information and made it available to the healthcare community around the world. So a lot of what I'm going to present to you today comes from great work done from physicians in China. First of all, what are the symptoms that they've documented with COVID-19? Fever and dry cough are the most common symptoms. These are very nonspecific symptoms. These are the same symptoms you may get with the common cold or with a flu. You can also get headaches, sometimes shortness of breath, occasionally diarrhea. Again, very nonspecific, and we're in cold and flu season, so many people may be infected with other viruses that cause the same symptoms, including in China. And what we've also found, based on the reports from China, where they've had 80,000 cases now, in most people, the symptoms are mild. And we've had several cases here in BC, and my public health staff have followed up those cases, and I can confirm that. They range from almost no symptoms to people who maybe have symptoms consistent with a cold for a couple of days. More recently, our most recent case is more severe, but by and large, for most people, they're quite mild. People who are older and have underlying health conditions, maybe perhaps heart disease or lung disease, can get more serious illness. And I'll talk about, just today, a new case was announced in our region that is an older adult with underlying health conditions and does have more serious disease. But for most people, this has been a mild infection. Now, how is it transmitted? This is always of concern with a new virus. This was of concern during SARS because in that outbreak, we saw a lot of transmission in healthcare settings, and that was of concern to healthcare staff, many of whom were infected and many of whom died around the world. We know we've learned a lot about this virus, and we're quite certain now about how it is transmitted. It's transmitted by small droplets of fluid from the nose and mouth of people who are sick. And this is, if they were to cough and sneeze, for example, those small droplets would travel perhaps a meter in the air, and then they would settle on environmental surfaces. And the virus, we know, can live for several hours if it's on an environmental surface. It's easily cleaned by normal household or hospital cleaning agents, but it can survive for a period of time on those surfaces. And so people can be infected in two ways. If you're standing very close to someone who coughs or sneezes within 1 meter, and they sneeze onto your face, you could be exposed to the virus. It has to enter through one of your mucous membranes. That's your eyes, your nose, or your mouth. Or the other way you could be infected is if you touched one of those surfaces where someone has coughed and sneezed. The virus can't get through your skin, but then you touched your eyes, your nose, or your mouth. You could be infected that way. And actually, this is how many common respiratory viruses are transmitted. This is how colds are transmitted. This is how the flu is transmitted as well. What we do know is it's not spread by people without any symptoms. Even if we might be able to test and find the virus in people who have not yet developed symptoms, it really does require that coughing and sneezing to produce these droplets that cause infection in others. And the data we have today demonstrates to us that it's only people who have symptoms that seem to be at risk of transmitting it to others. Important to note, it is less easily transmitted than influenza. This is really important. I'm going to show you some data later on. So not as easily transmitted from person to person as influenza, but it is more easily transmitted than SARS or MERS. And that's why we have seen it spread more easily to many more countries than those other viruses within the coronavirus family. What we've learned from the extensive good work done by epidemiologists in China is that most transmission occurs in households. We are not seeing transmission in healthcare settings by and large. There's been a small number of cases. Almost all the secondary cases are people who've been exposed to someone in their household. And in fact, we've had some transmissions in household settings here in Canada from some of the cases that have arrived from other countries. But we have not had any community spread here. And even in China, there's not a lot of evidence of spread in the community at large through big mass gatherings or other community events. What is the treatment for COVID-19 infection? Well, first of all, most cases will resolve on their own. And you'll hear, we've had several cases even here within British Columbia. The first 4 cases all resolved and are no longer contagious to others. And that's the case for almost all infections. There are no specific drugs yet identified for treatment, but there are lots of research trials underway in China and other places using existing antiviral drugs that we use for other viral infections. So far, no recommendations about what might be helpful, what might not be, but we expect to see results of those trials in the coming weeks. Is there a vaccine? No, there is no vaccine yet available, but there are more than 20 under development. And the first trials of some of those vaccines are likely to start in the coming months, but we likely would not see a vaccine available probably until the end of the year or about a year from now. So treatment by and large for people who have more severe disease is supportive care in hospital. They might need to get oxygen, they might need fluids, but there's no specific drug to treat the virus. So how has it spread around the world? So I talked about the fact that it began in Wuhan, which is the darkest area in this map of China, for those of you who know the map of China, at the end of December 2019. By the end of January, so 1 month later, it had spread to every province in China. So that's quite rapid spread. Wuhan, initially, of course, they didn't know they had an outbreak. They hadn't identified the virus. The initial cases linked to this animal market. Wuhan also happens to be a travel hub in China, and there was a lot of travel around the country at that time. So in the provinces around Wuhan and elsewhere, they could link many of these cases to people who had traveled to Wuhan. And then there was transmission primarily within household settings. What's interesting is the outbreak in China, which has been about 80,000 cases, is now resolving. So it took about a month to spread around the country. The peak was at the end of January. Now, by beginning of March, they're not reporting many new cases each day to the World Health Organization. So the outbreak is almost over. It's lasted about 2 months. So what did we learn about how many people were infected? Because you might hear alarming statistics in the news, 50% of people will get this once it arrives here. Well, if you look at the attack rate in China, assuming that they're not getting a whole lot more cases, they've had 80,000 cases, which sounds like a lot, but there's over 1.4 billion people living in China. So if we calculate the attack rate, which is the number of cases divided by the population, it's 0.006% of the population. That's 6 per 100,000 people. Now, just to put that in context for you, The Centers for Disease Control in the United States has estimated this year that about 10% of people in North America got this year's flu. 10% of people. This is 0.006%. Just to perhaps what that might mean, for example, in our region. Let's say we had an outbreak with the same attack rate here in Vancouver Coastal Health. We would have about 60 cases of COVID-19. And we'll talk about how many people might be at risk of dying. We would probably have a couple of deaths. That compares to, we probably get in our region about 100,000 people infected with the flu every year. We don't identify this because most people don't go for testing, but if we assume about 10% of people get it. So just to say it has a very low attack rate, this is because it is not as easily transmitted as the flu. And most spread, as I mentioned, occurs in households, but even within households, the Chinese estimated, and this is based on very good studies, because they really followed up their contacts very closely. They have thousands of epidemiologists in China. About 3 to 10% of all household contacts identified became infected. So the average case would infect 2 people. That means lots of household contacts didn't get infected. And we've had cases here in our region. We followed up household contacts. We've had a couple of instances where there's been transmission, but we've also had household contacts that have not been infected. So that's the situation in China. Very good data from the Chinese. Now, what about other countries? While China did put in quite, you might even call them draconian control measures, really restricted travel, as you know, that the virus did spread to other countries. We're a global economy. People travel around the world every day. As of today, the World Health Organization has identified cases reported from 76 countries around the globe. So there's about 195 countries in the world. So there still are more countries that have not identified cases, but 76 is a lot of countries. Now you may wonder, is this a pandemic? The definition of a pandemic is a new organism that is spread around the world. The World Health Organization has not yet called this a pandemic. They've said it's a high risk to be a pandemic, but the spread so far has, even though it's been reported from 76 countries, in most of those countries, they have only identified cases among travelers from places like China and some other countries, and maybe a few household contacts. There's only a few countries around the world that have actually had sustained outbreaks as they've had in China, and those countries are South Korea, Iran, and now northern Italy. And there are some smaller clusters in other places, including actually in Washington State, just south of us in the United States, where there is a community outbreak ongoing right now with a smaller number of cases. So again, only a few outbreaks. When we look at the cases that have been imported here to Canada, and we've had, as of today, 34 cases in BC, Ontario, and 1 in Quebec, we do expect that number to go up. They've all been returning travelers or a few of their close household contacts. There's been no transmission in our community. Some of the initial cases were coming from China when the outbreak started. Now, most cases we're identifying in Canada are returning travelers from Iran. And Iran is a country that doesn't have the same public health infrastructure as places like China, South Korea, Italy. And so the number of cases reported from Iran, which today officially was 2,336, is probably likely many, many more cases there. In British Columbia, we've had 13 cases reported from Vancouver Coastal, Fraser Health, and Interior Health. 4 of them have actually recovered completely. So they had mild disease, they recovered. They're now no longer at risk to others. So there's still 9 that are being monitored. All except 1 have self-isolated and been recovering at home. So they have not had serious disease. They've had mild to moderate disease. Today, we had our very first severe case of COVID-19 reported. You may have read there's also been some severe cases in the United States. And it was announced by Dr. Henry today that this case was admitted yesterday to Vancouver General Hospital and is in isolation in the intensive care unit. This is an elderly woman. It was acquired during travel. She is in her 80s, and she has many other comorbid conditions that put her at greater risk. So we do know from the reports from China that, as I mentioned, those are the risk groups. Same with influenza. One of the reasons why we're concerned about influenza circulating every season is that among frail elderly people and people with other chronic health conditions, it can be a life-threatening disease. And this is the group for whom it's more serious. This woman is getting the best care possible in our hospital, and there's no risk to any of the staff or other patients in the hospital. it's really important to emphasize that with these cases, there is no risk of, there is no evidence of transmission of COVID-19 anywhere in Canada in our communities. And I want to mention that because there's been a lot of fear, including right here in our own region, especially knowing the countries where the virus has originated. We haven't talked about your ethnicity doesn't increase your risk. So returning travelers, being in a place with an outbreak is what puts you at risk. There's no transmission in the Chinese-Canadian community. There's no transmission in the Iranian-Canadian community. I need to call that out because, unfortunately, with fear, we've seen sometimes racist comments or racist acts against people in our community. And we as leaders need to put a stop to that and indicate that no ethnic group is at greater risk. This is the people who are returning travelers, and the virus is not circulating here. I think that's a really important message. So this is again just some more information from China about and from the outbreaks around the world. In China, of their 80,000 cases, more than 80% had mild to moderate disease. Around the world, the WHO has reported just over 3,000 deaths today, 3,110 deaths. That's a case fatality rate of 3.4%. What does case fatality rate mean? That means we look at all the cases reported. In this case, as of today, there were 90,893, and that's on our denominator. And then we put the deaths on top, and we create that and multiply it times 100. So it says that 3.4% of cases have died. Now that's actually quite a lot, because we think about the flu. The case fatality rate for the flu is at 0.1%. So that's quite a bit higher. But we need to dig a little bit deeper. First of all, for young adults, it's much, much lower. It's less than 1%. And actually, what's interesting, there have been no deaths reported in young children under 10. This is a little different than flu. Influenza can actually cause quite serious disease in young children. And in the United States this year, they've identified over 100 deaths from the flu in young children. No deaths from young children. And they don't seem to be infected very often either. There aren't many cases in young children. So this is a different virus. It's not the same as the flu. But just like the flu, the death rate is higher in the elderly and those with chronic health conditions, and it's nearly 15% over 80 years. So, you need an overall case fatality rate of 3.4%. Some of the members of a community, if the virus is introduced, might be at greater risk. Some would be at lesser risk. And actually, the initial outbreak in Wuhan had a higher case fatality rate than the subsequent spread in China and in other countries where the overall case fatality rate is lower. The other thing I think it's important to note is that when we calculate case fatality, we put on the bottom, the denominator, the cases that we know of. There's likely many more cases out there that have not been diagnosed, given that this can cause mild disease in many people. You even hear it in Washington State. They think there's actually hundreds of cases in the community they don't know about. Iran. If we had the true number of cases here, the case fatality rate would actually be lower. So the case fatality rate for flu is an estimate, because we know we don't identify all the cases of flu. Otherwise, it wouldn't be 0.1%. So that's just to keep that in mind, that we're concerned about this. It is more severe than the flu, it appears, but we need to put these numbers in perspective. So what about travel? There's been a lot of concerns among people. I know people who've canceled trips. Can I travel at this time when COVID-19 is circulating in some countries around the world? And I would encourage you, Health Canada has a website for travel advisories, not just for COVID-19. They tell you if there's other safety risks in the countries that you might want to visit. So it's a great website to be aware of. Currently, they're advising people to avoid all travel to Hubei province in China. And that's actually not because of risk of the virus. That's because of the travel restrictions, that you won't get out of there if you go there. They recommend avoiding non-essential travel to the rest of China, to Iran, to northern Italy, and to some regions in South Korea where there are cases. There's no travel advisories of that level for any other countries. Now, Health Canada has taken actions as cases have been identified around the world, and they have, as we've identified outbreaks, they have put in place measures at our airports and ports of entry for returning travelers. Currently, travelers returning to Canada from Hubei province, China, and Iran, when they arrive at the airport, they're given information and told to self-isolate at home for 14 days after leaving those communities. The reason we say 14 days, the time from when you're exposed to the virus to when you might exhibit symptoms can be up to 14 days. It's usually around 5 days. And if those symptoms develop, they're then directed to call public health, and they're given the number. In BC, it's their nursing line at 811. all other returning travelers, even from countries that might have cases, are not being told that they have to self-isolate. They are told they can go to school, they can go to work, they can come work in our healthcare facilities. They only need to stay home if symptoms develop. And in fact, as I said to you before, people without symptoms pose no risk. So we believe this is perfectly appropriate action to take. I should say there are very few people now coming to Canada from Hubei province. There's no flights from there. There's going to be fewer flights from Iran. So what's happened as outbreaks occur, the number of people coming starts to drop dramatically. So we haven't for some time had anyone from China come from Hubei province with infection. Within Canada, I just want to mention that, and reiterate, I can't say it enough times, that there is no evidence of community transmission. So some people are wondering, well, should we have our Persian New Year celebrations this year? Do we need to worry? And our advice from public health is there is absolutely no reason to cancel those so-called mass gatherings, those celebrations. You can go ahead and hold them. The general advice, and we're trying to get this message out because it's good advice during cold and flu season and will prepare us if we ever do start to see community spread, is if you have symptoms of the cold or the flu, don't go to these mass gatherings, stay home. But otherwise, perfectly safe to hold these events. We encourage you to. It's also safe to go to school. We've had parents call us anxious about children coming back from class trips, maybe to places in China where they're not having to self-isolate. They think we should keep these kids home, and we're telling them there's no need to do that, that it's perfectly safe to go to school. People who've traveled somewhere or come back who have no symptoms pose no risk to anybody. And houses of worship. The reason why I mention that is that in South Korea, for those of you who may have followed this, their outbreak, they believe, began in a house of worship. So I've actually spoken to some of our community leaders who are concerned, also because many people who attend services in their houses of worship are elderly people. Is this safe? And I said, yes, it is safe. But you as community leaders, you can do a couple of things. One, you can also give the information to people that, look, if you're sick, don't come to services. God still loves you wherever you might worship. That is better to stay home. But also to give the messages about that we would like to give about hand washing being the best way to protect you. If you're holding events in houses of worship where you have communal food, people should wash their hands before they serve food. And also I think those community leaders can help with the message that this is not circulating in particular communities or among ethnic groups, and we need to call people out if they're making those statements. It's also safe to receive care in our hospitals and our clinics. So I mentioned the case in Vancouver General Hospital. It is perfectly safe to receive care at Vancouver General Hospital and all of the other hospitals and clinics in our region. All of our staff know how to assess people who might be suspected to have a COVID-19 infection, and it will not pose a risk to anyone else visiting. If you have family members there, you can be reassured. If you have to go receive care in any of those places, if you're going for surgery, no concerns. Now, the big question, because I've talked about the current situation, what if the number of cases increases? There's a lot of what if, and I think what the message I want to give is that we are planning for this. We are working very hard on public health to identify all the new cases. And I should just make one comment about how we're doing that. There's been some concern in the US, especially with the outbreak in Washington State, that there was not enough testing going on. They were very restrictive on who they tested, and this was a mistake because they missed cases. What you may not know is that up until last week in the United States, there had been fewer than 500 tests done across the entire country. They were only testing very select groups, people returning from China. We have not had that situation here in British Columbia, and I give credit to our colleagues at the BC Centre for Disease Control. Because the Chinese shared the information about the virus so early, they developed a test. We have our own test here in BC, widely available, and early on in this outbreak in Vancouver Coastal Health and Fraser, we had given doctors information about who the Public Health Agency of Canada recommended we test, and we changed that as there are new outbreaks. But we also said to them, you are free to test whoever you think you should test as a clinician. And I just want to tell you one story from that. The very first case identified that had traveled from Iran, this is before the WHO even knew there was an outbreak there, was identified by a physician in Fraser Health who saw a patient, wasn't among the groups for whom testing was recommended, but decided to test. And the WHO cited that case as some of the first evidence that there was an outbreak in Iran. So the situation here should give you some confidence that we have good testing. We've tested more than 1,000 people. The test is available in family physician offices, at our urgent and primary care centers. It is available in hospitals as well, but we encourage people with mild symptoms, maybe they're returning travelers, that it's not great to go to the hospital emergency departments to be tested. Those are crowded places. There's people with other chronic health conditions there. If you don't have severe symptoms, you should get testing in the community. If you don't know where to be tested, you can call 811. I do want to mention long-term care facilities because the outbreak in Washington State, if you know the story there, and I know I'm going a bit over time, but the very first case in the U.S. was a returning traveler from China in Washington State, identified, had mild symptoms, and was not isolated right away. That was in mid-January. There was no sense that there had been any transmission from that case, but about 6 weeks later, they started to pick up cases in a nursing home in Washington State. And now officials there believe it was actually circulating in the community for 6 weeks, probably causing mild disease in healthy people, but when it got into a long-term care facility, it caused some deaths, and it's a much more severe disease. I just want to reassure you, if you have family members in long-term care, for the last 15 years in this province, we've been working very closely with long-term care facilities to be able to identify influenza outbreaks and put in place to identify people if they get influenza-like illness, to isolate them, to put in place control measures. That good work will prepare them in the event that we were to see a case of COVID-19 in our facilities. We'd like to prevent that, so my plea to you is if you do have relatives in those facilities, don't go visit them if you're sick. Wash your hands when you enter, wash your hands when you leave, because someone would have to introduce a virus into those facilities to cause an outbreak. And if an outbreak were to occur, we would support all of the facilities in our region to manage that. And all of our hospitals are also prepared to manage serious cases. So I just want to end by saying that although we don't have community transmission, these prevention messages, they sound simple, but if we start practicing this now, and if we do start to see more cases, this will help. Stay home from school or work if you're sick. Cover your cough, so don't cough into your sleeve if you do have a cough. Important advice that people don't think about: don't touch your eyes, your nose, or your mouth. We tend to do that without thinking. That's how, if you're touching a surface and you touch your eyes, your nose, or your mouth, that's how the virus can enter your body. And wash your hands frequently after using the washroom, before preparing food, before you eat. If you're at work and you're going to grab a sandwich, you may have touched that elevator button, and now you grab the sandwich, you haven't washed your hands. I also wash my hands whenever I come home. I've taken transit home, I've come home from being at work. The first thing I do when I come in the house is wash my hands. Frequent hand washing is your best protection against this. And I'm going to end there and let you know, just to reassure you, I'm sure we'll have some time for questions. I know I've gone a little long, Penny, but I thought it was important, especially with the announcement today, so thank you.
Thanks so much, Patty. And you know, I just want to say that we're very, very fortunate in this province. We have a really remarkable public health system and really remarkable public health, scientists and practitioners, and it makes a really big difference when you're in a situation like this. So, I would say that I just said to Mary that I've heard a number of, media briefings on COVID-19, but probably 70% of what you said tonight was new to me. So it's a really strong message that we need to be able to have access to this kind of detailed information, because it's a story that you can get your head around, and it's very, very hard to do that, just with a quick snapshot interview. And so I really am appreciative, Patty, that you were here tonight and you gave such a comprehensive briefing, which I think really speaks to, a lot of the questions that people had. We will have time for questions after, but I want to keep the formal presentations flowing. So very briefly, we talked, we've got Laura Case and Vivian Eliopoulos, who together are our Vancouver acute and community leaders who make sure that the seamless system that we need to have to keep our public healthy and out of the hospital, and both on the front end and the back end, and actually able to deal with many issues at home or in our community facilities with our many partners. Like, that's their really critical job. And so I'm very happy to have them both here tonight. And we're going to share a number of sort of updates on different things, and including, a description of some of the great work that's being done around our reconciliation agenda, both in community and in our hospital. So I don't know what You guys, Vivian, you're going to go first? Thanks so much.
All right, thanks, Penny, and on behalf of Laura and I, good evening, and thank you for joining us. I laugh to myself when I hear about hand washing. Many people who know me will know that I just freak out about hand washing and ensure that we always wash our hands before we touch anything. And, you'll notice around our cookies, I brought microsand today and just ask everyone, use the microsand before they touch anything. And I know that my message is getting across. My niece, who often comes to visit, when she comes with her friends, the first thing she tells them, I hear her when she comes to the door, now before you come and see my auntie, you have to go to the washroom and wash your hands. So I would just encourage you to think about that. And I think as I think about our values as an organization, one of our values is really about caring about our people. And I hope you'll get a sense, given Patty's presentation, that for us it's really important that not only our public, but our staff and our physicians have access to information. And, we all know healthcare workers, and I know that our friends and our families look to us to be the source of information. And if I'm freaking out about something, well, I must know something, and I'm going to spread that fear, in a very outward way. And so our goal, in addition to really providing answers for the public, is also to support our staff and our physicians. And and Patty has been very gracious to come and to a town hall meeting tomorrow in Richmond that will be webcast across our health authority, again focused on our staff and our physicians to create an opportunity to hear from Patty directly, to ask questions, and with the hope that that information will be passed along to friends and families and partners out in our community. So again, heartfelt thanks to Patty and her team. I know they've been working tirelessly to support us. So onward to Vancouver, our community of care. And so Laura and I really want to take a moment, as Penny highlighted, to discuss some of our priority work. And our priority work really focuses on delivering exceptional care experience for all, including the frail elderly, those struggling with mental health and substance use, and other vulnerable populations. We also focus on enhancing patient access to high quality care, both in the hospital as well as the community, and I would also say primary care, as well as delivering innovative services for better health outcomes. And you're going to hear about some of that today. So one of our key strategic priorities, which I'm sure many of you have heard about, is access to quality surgery care is a priority for British Columbians and certainly a priority for Vancouver Coastal Health and Providence Care. And since 2015, we've been really focused along with all of our other health authorities on really increasing access to care. And since that time, we've seen an 11% increase in our surgeries across our health authority. Working together with Providence Healthcare, we this year are predicting that we'll complete over 89,000 surgeries by the end of this fiscal year, including 4,800 hip and knee replacements, exceeding the ministry target by 100 cases. So very significant for us. 72 deep brain stimulation insertions will be done this year, exceeding our ministry health target. And since last year, we have doubled those surgical procedures, and they're very transformative procedures for patients who are suffering with Parkinson syndromes. As well, we perform more than 1,700 cardiac surgery cases and over 487 solid organ transplant surgeries. So you can get a sense, certainly, of the work that we're doing. But at the same time, we're continuing to focus our efforts in addition to our scheduled cases. Many of our patients come through emergency and they need urgent and emergent access to cases. So while we're certainly focusing on our planned surgery work, we also ensure that we have enough capacity in our hospital to support our urgent and emergent cases, always ensuring that they meet our priorities as well. As we plan for the future surgery demands, we continue to work collaboratively with our surgeons to manage wait lists and optimally and consistently look at how we can continue to improve the utilization of our operating rooms. We're focused on growing our perioperative team, so we're actively recruiting, and also looking at how we can ensure from a wellness perspective that we're supporting a healthy work environment for our teams. Because we're not only wanting to recruit most amazing staff we can, but we're also wanting to wrap our arms around our teams to support them to be able to stay in our organization and feel proud to be part of Vancouver Coastal Health. In addition, we're building additional capacity. So we're looking at our bricks and mortar, we're doing modeling, and we're planning for the future. So one of our notable projects, which we've shared before, is the expansion of one of our surgical centers at Vancouver General Hospital. So we are extremely pleased to report that the expansion of the VGH Phil and Jenny Gaglardi Surgical Center is on track and on budget for completion in January of 2021. This is probably the most complex capital project that we've ever undertaken on the site. We continue to do work at Vancouver General Hospital in the Jim Pattison Pavilion, and at the same time, we're literally building an OR on the 3rd floor, directly above our ORs on the 2nd floor. So right now, we're transforming this vacant, massive space into a leading-edge surgical suite with 16 new operating rooms, a 40-bed pre- and post-operative care unit, and we're also weaving technology in throughout our services to maximize efficiencies, to enhance team communications, and for the very first time using technology in real time to support communication with patients' families and friends. So while you're sitting in a waiting room, you'll be given a number and you can actually see the progress of your loved one as they're making their way through the surgery environment. So it's pretty amazing. And at the time that you have the opportunity to go and meet them in the recovery room, you'll see a little notice on a board in the waiting room, and you'll be able to walk down and connect with your family members. So we're very proud about the fact that we've been able to launch that. We're looking forward to performing the first surgeries in our new operating rooms in spring of 2021. So certainly we'll be back to talk about that celebration. So in the meantime, we're continuing to improve our service offerings for British Columbia. And I'm extremely proud to share with you that on September the 18th, we held an information town hall regarding the launch of our gender surgery program. Together with our trans, genderqueer, gender variant, and gender nonconforming clients, and their friends and family members, we celebrated the launch of the province's gender surgery program at Vancouver General Hospital. And for our clients and their families and their friends, I can tell you this was a very significant event. It was also very important for us to celebrate the work that we did in collaboration with the Trans Specialty Clinic and TransCare BC. On October of 2019, we opened up the surgery program officially, making VGH Western Canada's first hospital performing lower gender affirming surgeries for transgender and gender diverse people. A welcome addition to the VGH surgery program, the gender surgery program provides British Columbians a quality alternative to out-of-province, and I would say out-of-country, care, and is consistent with our values and commitment to really caring for everyone. Both feminizing and masculinizing procedures are available, and the program is on schedule to meet the Ministry of Health targets by the end of March 2020, including 103 gender-affirming upper surgeries and 11 gender-affirming lower surgeries. And for us, the gender surgery program is just one of many examples in Vancouver where a commitment to care for everyone is driving positive change. I can tell you we're extremely proud about the launch of this program. Yeah, thank you. All right, I can tell you I'm equally excited to be standing here in front of Chief Ian Campbell and Leslie Bonshore to talk about our commitment to really provide quality and inclusive care. That's a critical word, inclusive care. And we can see through, as I share with you, the work that we're doing, that we're seriously committed to addressing the gaps that we have in health and social conditions between Indigenous people and other British Columbians. It's very serious for us, and we're very committed to it. So since 2016, VCH Aboriginal Health, under really Leslie's leadership, has delivered Indigenous cultural safety education to more than 2,000 staff as a foundational step forward. Not for the faint of heart, for sure. New culturally safe services and supports at community health centers and in the downtown east side are also evidence of our progress in Vancouver and remind us that there is a continuum of care that includes not only acute care but also community care. At VGH, we undertook an Indigenous cultural safety pilot from March 2018 to December 2019 to begin the hospital's transformation into a care environment where Indigenous people feel safe, respected and acknowledged. And through related work streams, each informed by Indigenous partners, we pursued our goal. And what we started to do was in addition to our education, we started to think about our environment by installing First Nations art and other visual elements to create a welcoming space for First Nations and Aboriginal patients in Vancouver General Hospital. We also supported the delivering of 6 hours of education to increase cultural competency of over 350 VGH staff in both the cardiac programs and the mental health programs. And we also increased staff awareness and access to information resources through such supports as elders and residents, which we're very thrilled about, as well as our patient navigators who are out and about. And when I run into them and my walkabouts in the organization will often tell me the differences that we're actually making and what they see in the organization. In addition, we're working in collaboration with our Aboriginal Health team and our VGH and UBC Hospital Foundation to transform the atrium space in the Jim Pattison Pavilion. So our goal is to create a space that's welcoming and healing, and we're doing this in partnership with Leslie and her team, and we're very, very excited and very grateful for the support and commitment as well of our VGH and UBC Hospital Foundation. All right, so I'm going to now just talk about one of our initiatives that really falls in our innovation sort of category, and we're again equally thrilled about it. And in a culturally diverse city such as Vancouver, language barriers can complicate the delivery of care as well. We've all experienced it, for sure, in a variety of ways living in Vancouver, whether you're working in healthcare or elsewhere. And to close the communication gap for patients, for better patient outcomes, we're piloting an innovative new solution, and it's a mobile virtual interpreter. I lovingly call it, you know, interpreter on a stick. And it's really an iPad that's on a mobile, you know, legs. And so the interpreter enables care teams to communicate with non-English speaking patients and families in real time. It connects users with a live interpreter for real-time communication, and the service supports more than 240 languages, including local dialects and sign language, which I think is incredible. VGH launched the pilot in January on our acute care elderly unit, where as many as 1/3 of our patients don't speak English. And I can tell you, when our elderly are connecting with an interpreter who can speak to them, they have the biggest smiles on their face. They finally connect with someone who understands them. And since our launch, we've introduced the virtual interpreter at 2 additional care units at Vancouver General Hospital, including the emergency department. Think about, you know, that would be a place where it'd be so important. To date, the service has been used in more than 300 occasions to interpret 17 different languages, and early anecdotal feedback is very positive, as you can imagine. Our care teams report that the service enables them to provide more timely, efficient, and appropriate care without the burden of unnecessary tests for patients, because they're able to get much better information, and they're able to develop much better plans of care. Equally important for us is the overall patient experience, and we know that that's improved. This month, we're expanding our pilot to 2 additional inpatient units, surgical outpatient units, as well as 2 community health centers in Vancouver, the Robert and Lily Lee Community Health Center, as well as South Hill Community Center. So now I'm going to pass along to my partner, Laura Case, and she's going to talk about some of the initiatives in our community sector.
Hi, everybody. Good evening. So I'm going to talk a little bit about some of the work that's happening outside of the acute care walls, things that you may have heard in the media, et cetera. So just things that are happening right now that you might be hearing about. So one of the ways that we provide care for people in the community is through a program called Home Support. Oops, move forward for you. Okay. Uh-oh. So home support is for people who are in the home who might be frail, elderly, or have some other disability that need to have care in the home. So a caregiver goes into the home 2 or 3 times a day, sometimes 24 hours, depending on the need. Historically within Vancouver and Richmond, those services have been contracted out to providers. And we're in the process right now as we speak, you're probably hearing about it in different media outlets, et cetera, of bringing that service back in home so that our home support care providers are truly integrated and part of the care team of the health authority. Then, as we're doing initiatives like looking at culturally appropriate care, hiring staff that meet and match our community that we're serving, we have a little bit more controls over it. As well, we can ensure that we have the most advanced technologies to support our home care workers to really connect with their clients who they're serving, as well as with the care team that's helping to support those people at home. So right now, this week, we are bringing back one more provider, and then we have one more provider yet to go in Vancouver. I'm just trying to, I know I want to make sure there's lots of time for questions, so I'm just going to move a little bit faster through the materials here. Another really exciting initiative that's happening right now as we speak is really through our partnership with the Division of Family Practice, the Doctors of BC, the Ministry of Health, and the First Nations Health Authority. And that's really the development of primary care networks. So you'll ask, what is a primary care network? Well, how many people here have a family doctor? Anyone have a family doctor? Great. And how many people don't have a family doctor? So a couple, really important. Saw one of my staff put his hand up, so we'll have to have a chat with him. So the primary care networks do 2 things. So if you have a family doctor, the primary care networks will be adding in nurses and physios and dietitians, mental health workers to connect and work with your family doctor so that if you or a family member have additional care needs aside from what your family doctor might have the most expertise in, they will have other care professionals to help provide the care for you that you need or your family member needs. The other thing the family care, primary care networks are doing is providing additional physicians and additional nurse practitioners for the Vancouver, Richmond, and coastal areas. So many, many more doctors are being hired, many nurse practitioners, so that everybody can have a family doctor or a nurse practitioner. So the goal is really to ensure that everybody in Vancouver Coastal Health has a family physician and is connected to one of these primary care networks. The work is very new. We're fast and furious hiring away. If you know any health professionals, doctors or nurse practitioners anywhere else in Canada or beyond, tell them to come to Vancouver Coastal Health and work with us. So really, really excited about that work that's happening. The next piece of work that we're doing is really improving the access to care and community. Has anyone tried to, everyone knows where the hospital is in their local neighborhood, I'll bet. But how many people have tried to access care in the community and gotten lost? Like, what number do I call? Where do I go? Anyone had any trouble navigating the community care system? Yeah. So it's a very, very common problem. So we're really looking at all of the care that we provide. How do we bring services together? How do we extend hours so we're not just Monday to Friday, that we work after hours, we work on the weekend, and there's one number to call at a community level, not 20 to call. So lots and lots of work happening in that area, and we're really excited about some of the great work that's happening. Even in Richmond right now, we have one number to call for all mental health services, for child and youth, all the way through to elders in the mental health continuum. So a huge advance from what we had was over 15 numbers for people to try to navigate, et cetera. So I'm really happy about that work. Urgent primary care centers. What is an urgent primary care center, and how is that different from an emergency department, and when do I access which one? So an urgent primary care center is really part of the care continuum. It's where you go if you've got a little bit less urgent items, such as, you know, you've got a cut on your finger, you've just got a really bad cold and you're wondering about what medication you might take. You have a frail loved one that's fallen and might just need a simple x-ray. So rather than going to a big emergency like Vancouver General or Richmond or Lionsgate, you could access urgent primary cares at your local community level. The goal in the province of British Columbia is that every community within the province will have access to an urgent primary care center. So for Vancouver, that means that we will have around 4 to 6 urgent primary care centers within Vancouver. A community like Richmond would have one, and then coastal and up the coast would have several. So already in Vancouver, we've opened one. Anyone know where the first urgent and primary care center is right now that's open? I know one that's been open, but one just opened yesterday. But one that opened over a year and a half ago, where is it? That's right. And we just opened up one that we had the announcement, our second one at the Reach Community Care Center in central East Vancouver, and that one has just opened up as well. So we have 2 already in Vancouver and a few more planned that will be coming forward. So we're very, very excited that this part of the continuum. The goals of the urgent and primary care centers are twofold. So one, to provide for that urgent primary care that folks have at a community level, rather than having to go to your local emergency for less urgent issues. The second goal is to attach people to primary care. So I don't have a family doctor, I live at this community level, I go to my urgent and primary care center, they notice I live at the local community level, and they say, would you like to have a family physician? We can attach you to a family doctor. So that is the goal of urgent and primary care centers. And lastly, we just want to talk about a really exciting new program that's been introduced into the Vancouver area. Another way that we're caring for Vancouver's most vulnerable residents and working with our public health colleagues on the overdose response activations is our overdose response van. One of the most recent initiatives, we went with thanks to the VCH and UBC Hospital Foundation and a donation from the TELUS Friendly Future Foundation in partnership with Portland Hotel Community Services, is the launch of our new mobile overdose prevention services, or our OPS service. It's a van that has just started operating in the Grandview Woodlands area last month. This is our first overdose prevention services in Vancouver, outside of the city center, and it is intended to serve other parts of the city where overdose deaths continue to happen, but where overdose prevention services have not previously been available. So the flexibility of this mobile van allows us to monitor client needs in different communities outside of the inner city, and able to quickly respond to changing locations of overdose and hours of operation. The primary goal of the OPS van is to provide people with a space to use their previously obtained illegal substances in a sterile environment where staff can help intervene if any overdoses happen. This is just one of the ways that Vancouver Coastal Health and public health leaders are working together with our community partners in order to serve our most vulnerable clients in our communities. And that is the end of our presentation. I'll hand it back over to Penny.
Thanks so much, Laura and Vivian. I think this is just a small sampling of some of the initiatives that are underway. I do just want to recognize that our Ministry of Health and our minister have, really made some very important investments in our health system, for which we are very, very appreciative. The money that is flowing into primary care is long overdue and very, very important. I think all of you know primary care is the foundation of our healthcare system, and for everyone, we're going to take your names, those of you who don't have a family doctor, but it's really important that we provide better access and that we start to take these assets that, we are just bringing on stream and figure out how to really make them work for the whole spectrum of our public. They're open 7 days a week. These urgent primary care centers, I was so proud to be at REACH this weekend. We've got the chair of the REACH board here today. To see this very beautiful clinic opening up and knowing that you can go there with an issue that's urgent. And often, people don't want to go to emergency, so they sit at home. And sometimes that's not a good idea either. And these are places where you can go. It's low key. It's very well equipped, and you can have some things sorted out. And sometimes they'll say to you, you do need to go to emerge, and we're going to get you there and make sure you're properly taken care of. And it's going to be a remarkable asset as we start to get these things rolling and understanding, what the needs are of the communities and how we can, continue to tweak them. It's going to be fabulous. The surgical work and the capital renovation that's happening at VCH are obviously funded by the ministry. It's the first time in a long time we've actually really had incremental resources to start to increase access to surgery. Home support, same thing. Laura's and her colleagues around other communities of care have, we've been able to invest money in home support workers and community programs and adult day programs, residential care. Like it's really wonderful to actually have that chance to really continue to make things better. So we are very appreciative. If the Minister of Health is listening, we just want to say we do appreciate it, and we're doing our very best, as you can see, to try and make the best of those resources. So I'm going to open it up to questions. There's tons more things that we could talk about, but I think we want some time to hear your questions and try and answer them. And maybe what I could do is ask Patty Daly and Vivian and Laura to just come on up and take a seat here, and maybe I'll ask I'm going to make my two board members come up to the front and just sit with us, because this is our meeting, right? We have to own this meeting. So Howard and Alan, if you could just come up, just grab a couple of chairs. And so let me just open it up. Yes, okay, in the back. I don't know your names, but
You know my name.
I do know your name, that's right.
I will. Just
My
give me a second.
HEU friend.
Yes, because you used to be at my place. Karen McVeigh, Hospital Employees Union. I'm a long-term care aide at Dogwood Lodge. Love my job, by the way. So can I ask sort of two questions?
Sure,
sort of?
absolutely.
Okay. So I've been a care aide for 25
You
years.
can't pass a motion, but you can ask two questions, okay?
Well, you're lucky I like you. Shh, you have to behave. My boss is here.
Oh, okay.
Over there. So my question. Okay, so my two questions. So I've been a care aide Dogwood for 25 years. We're getting a brand new building pretty soon, so I'm all excited. So since our special care unit has shut down, we found like the outbreaks are less because we don't have, because with Alzheimer's and in a locked unit, we've had so many, like H1N1 several times, the Norwalk several times. So with this new virus, we actually had a family member got upset because we had a family member come back from Taiwan, and they were quite upset that this person was in our care home, the visitor. And we did isolate the person into the residence room, but it did cause a little bit of an issue. So our issue for the staff, as I'm the chairperson of the local, by the way, is that so when we had all these outbreaks, and we actually had one where we've shut down the care room several times. So family members, this is our issue, is the family members still come. They don't put on the mask. We have a nice hand washing thing at the front door when you come in, lots of hand washing. And these people come in, they got the cold, they got the flu, and so then we get sick. Our residents get sick because they're elderly, right? So our issue is like with this outbreak is that even though you're saying all this stuff, we find that family members are coming in with their cold, their flu, and so they're not listening to what you guys are saying. And I know there's the fear that they're taking the masks that we need for our jobs, right? I've seen it in the hardware store, they're taking a mask, like, you know, for the dust. So that is our concern. We're not concerned about getting the outbreak because we've been through it before. So we'll survive. We all got the flu shot. We got a shot, so we're good. It's the family members that we're scared of, right? So just to let you know,
Okay.
you know, because we all see this. We saw what happened in Richmond. My second question, I don't even know that was a question because you threw me off, is that so I represent HU in the Violence Prevention Committee. So this is a violence question because we get hit almost every day, just to let you know, but we love our job. Today, there's a big thing about domestic violent leave, 5 days, which is awesome because we have that in our collective agreement. But when I went on to the Coastal website, I looked for 2 hours. And so we have a policy, if a person comes to emerge, there's a policy for that. But if I, as a person of violent, same-sex violence, right, there was nothing in my workplace that would help me. Right now we have labor with this thing, but in my workplace, Coastal has no policy about domestic violence for staff. So we've been looking, the Violence Prevention Committee's been looking. So for a person of domestic violence, we need to have, I know you're here, so I wasn't gonna say anything, but it was bugging me.
No worries.
And also those new programs you got there for the First Nations and the interpreter, we would like that to come to us. We're getting a new building, but you know, we need that to come to long-term care. Because we get forgotten with all this fancy stuff. Like that interpreter stuff would be good in my care home, especially in my new building. First Nation stuff would be good in my new building. Or anywhere else in long-term care that belongs to Coastal.
Okay.
So that's all I have to say.
Thank you so much. So a couple of things, because I think you've asked 3 really important questions. In terms of the first issue, I think that, you know, you've cued us that there's still more work to be done in long-term care, and I think you've got Patty Daly here and Laura, who are your 2 senior people responsible. That's right. And so we take your point, and I think, you know, we'll regroup and see, you know, what are the things that might be able to help, you know, our visitors into long-term care, and particularly Dogwood, you know, pay a bit more attention and help do their part to protect residents and staff. I think in terms of the domestic violence policy, maybe Brett Sparks, you could stand up. We got a new VP of employee engagement, and we're very happy to have Brett here. And I think you heard that question, and you can take that back, and that's something that, you know, we'll look into. Yeah, maybe you guys can. Okay, thanks, Brett. And then I just wanted to go to your shout out that you'd like Leslie and her program to come to Dogwood, and that's what we want to hear. We want to hear from all of our coastal authority that you're keen and you want to go. And I think the question is how fast is the pace that we can keep up. But we had a very good discussion about that at the board. The board is very determined that on a very regular basis, we're moving that dial that, you know, across all of our various activities, our services, our facilities, that actually our staff and physicians are all feeling comfortable and educated and with the proper skills and attitude to make it culturally safe for all of our community, and with a high emphasis on our Indigenous community. So I think we hear you. I'm not going to guarantee it's going to start tomorrow, but it's terrific to hear that. Sorry. There you go. It's already started. Okay. Okay, now we had another question at the back there. Yes, in the green. In the green. Sir. Oh, I'm sorry, ma'am, I couldn't see you there. I just, Please.
Thank you. Thank you. I am an immigrant from Japan to Canada way before most of you guys were born.
oh, not me. No, no. No, okay, let's get our birth
19-
certificates out.
1969.
Oh, yeah.
Those days, airplane was too expensive. I took a boat,
All right.
okay? And that's, I never regret. I made lots of mistakes in my life coming to Canada, and I didn't have an abortion for my son. I was in Austria. Now, medical system, I know I've been so healthy. Just now, I started to notice, I think, in olden days, it was better for me because I left, it's 1977, I moved to Austria. 10 months later, I didn't want to settle down there. I was 8 months pregnant. I chose to come back 10 months later. I worried about the medical cost to give birth. It's all covered because
That's
I
right.
came back within 12 months. I didn't know that. I'm very grateful. And the VCH, I was taken care of, the wonderful nurses. After that, I've been healthy, except just 10 years ago, I had a polymyalgia. I don't know if you know this illness.
Yeah.
Anyway, now 10 years, at age 78, for the first time, I need a doctor.
Aha.
It's called gastro or something.
Yeah.
It happened October, November, finally, it didn't bother me. Just the other day, I went to see the doctor. Doctor said, I have to send you to a specialist. Could you tell me why one doctor's closed, another doctor just yesterday, and the lady at receptionist who made a call, oh, at both doctors, you may have to wait for 1 year. And I know, I talked to an 83-year-old gentleman. He told me that he had to wait how many months for a certain illness. Therefore, I've heard so many nice things. And also another thing, this coronavirus issue. The lady didn't touch upon, and it's personally affecting me. Allow me just quickly. And so 2 questions, could you answer me, okay? First one is most important. If I wait for another 1 year, I will be 88, I'll be dead.
Yeah.
Okay? Okay, coronavirus.
Yes.
I knew a Japanese mother in Osaka was supposed to arrive here March 25th with 2 children. I discussed a long time what the situation is, and Japan is really, entire school and the whole March is closed. Nobody, some community activity, everything's canceled, okay? Anyway, my reason I'm glad she agreed to cancel the trip is my own experience about a few weeks ago. I'm a Canadian, I may look Japanese, but because of the media news, China, 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 Japan, 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 due to that big cruise boat of Yokohama. Now it's coming up at Italy, there. But people in Vancouver got the notion. I stepped in my apartment. I stepped into the elevator. No Asian, white ladies there. We knew each other, okay? I stepped in. She immediately pulled the sweater, covered the nose and mouth. I felt so unpleasant. I didn't do anything. Just a month. Therefore, also, I have a friend in Austria. I was going in June, second week of June. Another Japanese lady will come. I was going to take her to Vienna, etc. Just the other day, my friend in Vienna told me, I'm very worried about me or my doesn't matter, Chinese people. We are healthy, yet, this is my experience.
People are afraid.
And I want the city will educate the non-Chinese looking, Japanese looking, whatever, people are not carrying the disease.
Yeah, okay. So thank you so much. Two questions. So I'm going to deal with your second one very quickly. I think you've raised an issue that we know, unfortunately has been happening on occasion in our community, our broad community. And I think Dr. Daly has done a lot of work, the Minister of Health, our Chief Public Health Officer, Dr. Bonnie Henry, and our local public health people have been working with communities, with schools, done a lot of work in Richmond where we're experiencing some of the same type of thing. It's a really important issue. We can't fix all that. It's our community, all of our community. And one of the best defenses against that is the kind of information that Dr. Daly shared with us tonight, because it helps you understand what the real risks are. And it helps you be able to let go of your fears of things you don't understand. So I'm sorry that happened to you. And I think we are aware of these dynamics and working hard to be part of the work with local governments and nonprofit agencies to try and send a clear message that kind of thing is unnecessary and it's not how we're going to have a healthy community. Just to your first one about specialty referrals, that is a challenge for us as a health authority. We actually don't have all the ability to understand, waiting lists in doctors' private offices. But it's definitely something that as we are building our primary care networks, having primary care physicians be able to better and more quickly access necessary specialty consultations. Sometimes they could be virtual, over a mobile phone if that's appropriate, or in person when that's necessary. We have a lot of work to do to try and streamline that and smooth it out because we know it's very uneven. And we see our primary care work as a big step toward trying to sort that out. So I can't solve your problem tonight, but I think there's lots of work underway to try and diminish the amount of time that people are waiting actually to see necessary specialists for consultation. But so thank you for raising that. Yeah, I have Colleen Fuller. Nice to see you here tonight, Colleen. Congratulations. Colleen's the president of REACH and was opened our second Vancouver urgent and primary care center on the weekend.
And it was great, actually. First, I just want to say thank you so much for this. This is the first time in a long time I've been to an open public meeting with the board of the health authority, so appreciate that. We did open an urgent and primary care center on Saturday, formally opened it, and we're very optimistic. It's a collaboration with Coastal Health, and it was a while to get here, but we're very optimistic and appreciate the work that was put into launching the UPCC. It's going to be a really positive thing in our community, I know that. I had one question, and I was kind of surprised that there was no discussion this evening about community health centers and the strategy within the Coastal Health region around community health centers. And I'm talking not about the VCH clinics, community clinics, but community-governed community health centers. And as you know, there has been a long-standing demand is probably too strong a word, but there has been a strong appetite for globally funded community health centers across the province. There was a commitment by the by the current government to move forward, and I know that they are moving forward. I absolutely know that. But what I'm interested in is what are the plans so far within the coastal health region for community health centers, and that includes the plans for funding.
Yeah. So the funding for community health centers is coming directly from the ministry, and in some cases it will be flowing through us, and in some cases it's uncertain. So I would say a couple of things. From the board's perspective, we are very, very committed to, we see community health centers like REACH, who has a long, really remarkable history in this city, working with the broad community and very vulnerable members of the community. And we have many organizations like that that have never been a formal part of our health authority. And you know, we have recently announced, you might have heard, the RISE Center, which is with Collingwood Neighborhood House. And you know, to be really honest, it was only until I worked at the city that I started to really realize the rich breadth of, you know, neighborhood houses and community health centers that we actually have in our city. And so we see those organizations as a place where we as a health authority can really learn a broader, more holistic model of primary care, and you know, one that reaches into the social determinants of health and really can impact people's lives, not just through their medical care, but also other activities and services that can help them basically have a higher quality of life and you know, be able to be healthier generally. The actual plan, I would say that our primary focus at the direction of the ministry is getting our UPCCs open, getting our primary care networks open and funded and hired up. And then, you know, the ministry is at the same time working in parallel with different community health centers. And I think at this point, our major commitment is we want to learn. We want to really embrace those organizations, and they need to be part of the broader primary care networks. And I would say that our divisions of family practice, who've done an enormous amount of work, are really going to learn from those organizations because, as you well know, they do business in a different way. They're community-led, they have community governance, and they concern themselves with things that are beyond the regular, long-standing kind of scope of how we do business in our organization. So I would say we're on a journey, Colleen. We're not quite ready, and we don't have all the tools to be able to say, well, it's going to look like this. I think we're coming together with the government, and the minister has a deep interest in this, as you know, and is working hard. He has some very specific ideas of, you know, how he wants to see things happen. Our first wave of activity has been the networks and the UPCCs. And in some cases, we've combined those two concepts, which we did at REACH, and we're looking to see if that's possible with our next few that are going to open. So I hope that helps. It's not, you know, it's not an explicit plan, but it's very much an openness to bringing those two kinds of organizations together. That'd be great. We really need the help. We actually had Collingwood Neighborhood House came and talked to our board. It was very illuminating, I think, for all of us, certainly for the board, and I think even for all of our staff. Like, I think we don't understand always the extent of the kinds of things that community health centers are able to do and how far, you know, they get value out of every dollar they have, and it's a big learning for us. So we were very appreciative of that. So thanks for bringing that up. Yes, I'm just wanting to just spread it around. Maybe in the back? Yes. And then I'll come back to you.
Hi, my name is Jenny Conkin. I run an organization called Whole Way House Society. We support vulnerable seniors in-house to provide community building programs and tenant support services in the downtown east side. So thank you for your work at VCH. We work very closely. We're very thankful for the great work that you do. I've had the opportunity to present to some of the operations directors, and in the work that we've been doing and working in cooperation with Vancouver Coastal Health, we've seen enormous improvements in our seniors who are vulnerable to homelessness or have already experienced homelessness and coming into housing, who often aren't able to access healthcare services due to health decline or different capacity.
Right.
And we're wondering if the board might be willing to look at a different funding stream, as there's not currently one to provide in-house support services that actually are very proactive in preventing extreme healthcare costs for people who are in a gap between independent housing and assisted living, to provide those on-site community building programs which create organic community that's very supportive, but also those very vital support services so that they're able to access case managers, get to the clinics, all the amazing services that you provide that many seniors who are vulnerable aren't able to access, whether it's due to confusion or inability or capacity issues. Yeah, so we're working very hard to provide those services, but would love to look at a potential partnership with Vancouver Coastal Health so that our seniors, who are actually our fastest rising demographic in our homeless population. They're now 24% of our homeless population in Metro Vancouver, and that is going to continue to grow if we don't have some services in place for them so that they're able to age well in place with dignity and access the amazing services that you guys do as we work with case managers and our amazing home support services to be able to help seniors access those services.
Well, you raise, like, seniors who are homeless is, is really a very uncomfortable, reality in our city, and it's grown, as you've indicated, over the last 10 to 15 years. And so, obviously tonight I can't answer that, but I think that we're working really hard to, look at our population, our most vulnerable populations, and, what are the kinds of services that they need, and what are the ones that only we can provide, and what are the ones that, we can probably participate in and share with local government and nonprofit organizations and even other branches of the government. And so, not knowing the specifics of what you're talking about, I think our organization is, we're looking for ways to transform how we can get the job done and to, work with partners. And I just think we're very cognizant of our very vulnerable populations. And, I would think, Laura, this is the big cheese of our Vancouver community. And, I think it's really about, how do we actually get a plan, and what are the component parts, and, what funding needs to flow where to achieve it. But the need and the issue is very, very significant. So we really appreciate your work. Thank you for coming tonight. Yes. I someone in the yellow. Yes.
A couple of comments and a question. So I'm going to try to organize myself as well as I can here. But my name's Zara Ismail. I'm the Executive Director of the South Vancouver Neighborhood House and also the Marpole Neighborhood House. So South Vancouver is a pretty disconnected community within, it's actually several neighborhoods, Sunset, Victoria, Fraserview, and Killarney. That's historically underserved. There's a lack of transportation. There aren't a lot of community health services or doctors available. High density of seniors. Champlain Heights is a very isolated community within South Vancouver. And so we know that the Community Health Center run by VCH at Knight and 49th will be relocating to Pearson Dogwood. So I wanted to comment that there's going to be a huge gap in service for the already kind of underserved community in South Vancouver. It's 80% visible minorities, 56% newcomers, almost 70% non-English speakers. So there's some real access issues. And so I'd like to figure out a plan to get ahead of that to support the neighborhood and the people who live in it before the Community Health Center is relocated. We run 2 adult day programs through South Vancouver Neighborhood House, and we really appreciate the partnership with VCH. It's a fantastic partnership, but our wait lists are very long, and there are many seniors who are trying to age in place and need that adult day program support. So, of course, I mean, this is not news to anybody in the room here, but we need more adult day centers to be established. I understand that's part of your strategy, so I'm just reiterating that it's pretty urgent from our community's standpoint. In addition, we need urgent primary care centers in South Vancouver. There aren't any hospitals nearby at all, and transportation, like I already mentioned, is a huge concern, and the multilingual access as well. I wanted to share, neighborhood houses, you've already mentioned that they are pretty well spread across Vancouver. And we can be strong partners in terms of getting messaging out there into community along with other nonprofit agencies. So I hope you do consider us a partner and reach out to us with specific asks about, with this COVID-19. This is what we want you to share with the community. If we could get support with translation services, we have huge groups of multi-ethnic, multicultural seniors that come to the neighborhood house. We've witnessed firsthand that there is a lot of racism that's popped up. A lot of our Chinese groups are actually self-isolating, even if they've had nothing to do with Wuhan for a long time. And these are vulnerable, marginalized people who really need the social connections. And we've seen that they're taking it upon themselves to get ahead of the racism and just sort of stay at home and cut themselves off. So if we could get access to some of that information so that we can help to be your voice on the ground with community, would be really happy to do that. And then if I can take off my South Van Neighborhood House hat and just ask a stupid question probably. A couple of years ago, my dad was in the hospital and he had got C. diff. And I remember being told that there was a lot about transmission of C. diff being very highly contagious and about sanitizing cell phones. And I wondered if there was any tips that you could provide in terms of sanitizing cell phones, because they're in our hands all the time. I think people cough and touch their cell phone all the time. So I just wondered if there was anything practical that you could share.
Okay, so that's a really technical question I'm going to leave to the health officer. I could just tell you that after my granddaughter has been on my cell phone, I always feel like, I should probably run this under hot water and soap. But Patty, do you have any tips?
I don't know if I'm the expert on cleaning cell phones, but I think the advice would be, since I'm not sure how to do it, you might want to check with your carrier how to clean it, but it's washing your hands. If you're using your cell phone, wash your hands afterwards. Because keyboards, other things, we're not cleaning them every day. But I'm not an expert on that, so I would ask.
So but C. diff is another whole issue, and as far as I know, C. diff is not spread by cell phones. No. Yeah. C. diff is a very unfortunate and very difficult complication. It's been around a long time. We've learned a lot about it, and there's some very innovative new therapies for people with refractory C. diff. We are doing a lot of work across our health authority and our institutions to try and minimize C. diff and get ahead of it. And so, I think that back to hand washing, that and understanding the risk factors for C. diff are probably the most important things. I just want to go back to your question about South Vancouver and sort of Southeast Vancouver, right? The board's very aware. We've actually highlighted, I've got, Wendy Au is a board member of ours, and you may know her, you probably know her from the city, very, very knowledgeable about the city. And we have flagged for staff our deep concerns about, the fact that South Main, what is it, South Vancouver, right? The clinic on Knight Street? It's the South Community Health Center. It's been there for years, and I'm very familiar with the population that goes there. And I think when we thought about the plan to move it to Dogwood Pearson site, we just didn't understand in some ways some of the dynamics. But with this opportunity, with the primary care resources and the UPCCs and the investments in Community Health Center, what that area of the city that you described is very much on our map. It's a difficult, as you described, there's very little commercial development. It's very low density, small private homes, right? And then the big Killarney, I've got my eye on Killarney, right? It's got all that land around there. So I was going to make a trip to the city and talk to them about that. But we need to leverage some opportunities to actually address those issues. And I just want you to know they're definitely on the map. We have, we've been given the chance to really do something significant and actually mitigate, the decisions around moving the South Main Community Health Center to Dogwood Pearson. So I feel very good about that, and I think the board, really was strongly expressed our concern that we were going to lose valuable assets. And that's a very old facility, as you well know, and so our hope is that we can replace it with something that, you know, is a lot more contemporary and modern and, you know, properly outfitted. Okay, so Lynn, yeah.
So my name is Lynn Filiatro. I was an emerge physician for 20 years
You
at
want to just stand up,
VCH.
Lynn, so we can hear you? Yeah.
Sorry. I'm Lynn Filiatro. I was a physician at VGH for almost 20 years, and then I was involved with physician engagement. So I want to thank everybody for all the hard work you did, especially explaining so clearly, Patty. Patty, it was great. I wanted to follow up on a question I had last year at the VGH Open Board. The question was concerning measuring the user's experience with the rollout of CST, which is our electronic health record. And the question wasn't really fully answered at the last board, so I met with Beth Snow, who's the lead for CST, which is the electronic health record. And I was surprised to find out from her that there was no support for gathering the user's experience. I've attended several town hall meetings where we hear about all the great necessity for the electronic health record, and we get pretty much a biased opinion of how things are going. It's not the impression that I'm getting from frontline staff, both nurses and physicians. This has been a big transformation, the way they give their care, and it's well known in the literature, if you look, that one of the drivers of physician burnout and nurses is the electronic health record. In Canada, we had the CMA presenting just this past Sunday, 1 in 3 physicians suffer from burnout. And that's the average. So there are segments, anesthesia, frontline, emerge, where in ICU, where that number is way bigger. We've also know that burnout can lead to suicide, and unfortunately we had somebody in our region that did commit suicide, a young physician. So we've now put CST on hold before we roll it out to VGH, and I would plea once again that we survey the users, and for both the good and the bad.
Yeah,
I totally agree that we had legacy system, and it's really important to have a great system. But I would urge you to look at the impact that it's having and to use the 1-year delay that we have to mitigate before we roll out to more physician, nurses, and allied health. And it's not that it's not necessary to have an electronic health record. I was a super user of the previous one. I was a super user of Care Connect. I think it's essential. But what I'm saying is using an American system that doesn't follow the flow of how we provide care actually decrease our efficiency and adds to burden.
Thanks so much. I think that it's a really good point, and yeah, sorry, Vivian, do you want? Yeah, go ahead, sure. No, go ahead, please. But you might want to, why don't you come over here and use this? Yeah, that'd be great.
So Lynn, thanks for your comments, and I think for Vancouver, our community of care, Dr. Vinay Dhingra is our physician champion, and we recently had a town hall for providers. We had over 100 providers attend, and to really talk about the solution coming, to get some input, etc. But as part of that process, we did actually do a survey, and we had a series of sessions to really focus on lessons learned. Because I agree with you, I think we've had really 2 significant implementations, one in Coastal as well as one in Providence. So perfect opportunity to learn from the experience and then to move forward and to think about those as we plan the implementation in Vancouver as well as Richmond. So we are taking it very seriously and moving forward, continuing to engage with our providers as we move forward. And you're absolutely right. We've been given sort of a gift of time in the sense that we've got some opportunities now to really, in a very focused way, work with our providers around that. So thank you for raising that.
Yeah. Thanks so much, Vivian. Okay, so it's 2 minutes past 8, so maybe 2 more questions. So I'm going to, 1 and 2. So do you want to go ahead? Yep.
Hi, my name is Arguna Wakil. I work with Mosaic. It's one of the immigrant serving organizations. And I should say that I'm a student of SFU Public Health, Masters of Public Health program, because my professor is sitting here. I'm also an internationally trained doctor, I came to Canada when I did not speak English, so I learned it. But now, working with newcomer population, we see there is a disconnect between the service-providing organizations that provide service to newcomers and the medical service providers. So basically, we were hoping that the launch of community health centers may resolve that issue. As Zara mentioned, some areas in Vancouver are densely populated with newcomer communities, and they do require help, and that is costly to the system. Versus if there was a connection between the service providers, both health and community, that may actually help in keeping the population healthy as well as reducing cost on the healthcare system. The fact that we are now using the online interpretation services, that's great. But then similarly to like First Nation community, newcomer communities as well have healthcare practices that are getting in the way when they are accessing healthcare system. So it would be great if the two service providers could work closely, and then that could be addressed. Thank you.
Thanks so much. I think, you know, we're doing a lot of work with the Division of Family Practice, which is basically all the community-based family practitioners. And I think that it's the first time in my career, and I've been working at it for a long time, where there's actually been a way to gather those providers in. They have been very isolated in small clusters and groups, and some of them just plain working solo, to care for their patients, right, with very little ability or inclination in some ways to think about the community at large and what's happening. And we know that we have providers who are from different communities who are retiring and are going to leave big gaps behind for their patients. So I think that was, you know, one of the really wonderful things about the discussion the board had with the Collingwood Neighborhood House, because they brought a young physician, they brought other people in their neighborhood house and talked about the different programs that was, you know, revealing of the kinds of things you need to be doing, as you say, to actually address the needs of our immigrant communities, our refugee communities. And so it's a work in progress. And I think the CHC initiative, you know, is absolutely the best way, the most expeditious way to actually start to really ramp up the curve of that integration. It's not going to be the easiest thing in the world, because I think, you know, my profession is, you know, they've had their way of doing business for a long time, right? But I think they're very, very open. The Vancouver division is you know, really trying to think about the community rather than just their patients. And through that, they, you know, I think they're starting to realize that there are partners like CHCs that can really make a difference in terms of how effective they can be. So what I can say is we're really aware of it. Did you want to say something? Yeah. The board, you know, has been part of these discussions, and, you know, we're really encouraging the organization to, you know, branch out and you know, use this opportunity to start to create bridges that have never existed before.
You asked us to come sit up at the front, so be careful what you wish for. I've been on the board for 4 years, and I'd say in the last 1 year, the number of times that the word partner or partnerships has come up around our table has exploded exponentially. And the theme I'm hearing from many of you is that you represent groups that you believe would make great partners for us. What I challenge you with is I would expect that you are receiving open doors to have conversations with us about those partnerships and how they work. If you're not, my challenge would be somehow you got misdirected to the wrong person, and or keep trying or elevate it, because partnerships is absolutely a crucial part of how we see moving forward. We know we're resource constrained, and there's so many valuable insights as well as resources that are out in the community. So we embrace it, but if somehow your message isn't getting through, find a new way to get it through and or straight to the board or whatever it takes, because it is absolutely a priority for us.
Thanks, Howard. Thanks very much. And one last question.
My name is Gudrun Langhoff, and I happen to live in Marpole. So I'm really chuffed that we get a center there because we've been long underserved. I'm not suggesting for a moment we should steal from one part of the community to bring to the other.
We haven't quite located it yet, but it's going to be in the south.
If it's going to be in Dogwood, that'll be just fine. I can bike there.
But okay, Dogwood, yeah, that's going to be there.
In any event, I'm also part of a larger organization, COSCO, the Council of Senior Citizens Organizations of BC, without the T, and we don't sell you anything. In fact, we will take your money if you want to give it to us, but we don't sell you anything. And we've been worried about the business of contracting out services that we believe ought to be given or provided for by the public service. Seniors have been, and I'm addressing this with a seniors lens, obviously we're concerned about our families and friends as well, but we've been worried about the quality control that happens when you have private companies or even some nonprofits who are not really living up to the kind of service that they promised to provide or people thought they were going to provide. So when I hear people talk about partners, my alarm bells go off like crazy because we have, over the last 50 years, gone from where the services to seniors who were vulnerable, the care, went from the public service into private hands. And I think we've heard about 4 care homes that have been really problematic in the press. That's a tip of the iceberg. So and it's not just long-term care, it's also assisted living. And public money goes into those places. And there are health problems. And I know when we talked to the person that was is in charge of the Fraser Health, for example, about the homeless woman that was being discharged from the emergency care from Surrey, was sent to Chilliwack into a shelter because she didn't have a place to go to. We're outraged by that. No, the health people aren't into housing folks. Of course not. But there's got to be a connection. And I don't know that we've solved that one yet, but it's on our minds. It should not happen to anyone, let alone a vulnerable senior. They end up being part of a revolving door, right? They keep coming back because they're not being taken care of properly. And we understand that you can't have people in, let's say, VGH, on that 7th floor, there are about 20 seniors waiting for long-term care facilities. I just happened to notice that when I was there last time visiting someone. So I know you've got your plate full of all kinds of things, and we're really happy about the community
UPCCs?
health. Well,
CHCs?
the reach for
Yep.
sure. We want
Yep.
more of that.
Yes.
I know years ago we were championing it because we saw it happening in St. Catharines in Ontario. Go figure what they're doing to their system now. But anyway, I won't get into that. Thank you so much for all that dedication. And I like these open forums. I think they're very important because people can speak about things that was close to their hearts.
Right.
And COSCO is a provincial organization, so we'd like to see this kind of a forum also up in Sunshine Coast and everywhere else, because Lower Mainland isn't the only place where things are happening. So thanks.
Thank you so much. And just a couple of points. Thank you. I'm glad that this format and initiative is working. We have had, since in the last year, we've had one in Richmond. We had another one in Vancouver. It's our second one in Vancouver. We had one in Squamish. We're going to have one in Bella Bella. We will definitely have one in Sechelt. So we really are, we recognize that it's not just the Lower Mainland for Vancouver Coastal. Our smaller rural communities are really important to us, and they have very special problems. So we really appreciate the feedback that this works and that you appreciate the information, and we want you to share your concerns, your good and bad experiences. That's why we're here, and the board definitely wants to hear them. It does make a difference. And we have a terrific organization, but we always know that any organization, we can always do even better. So we're working hard at it, and I think we have some really, really exciting things happening that address a lot of the things you're raising. Our partners are really important to us, and I hear what you're saying. We have partners that are local government. I would say around housing, we probably have the best and most intense relationship with BC Housing, practically of any health authority in the province. So we're very aware that, A, we can't do everything, but we need to keep that connection, and there's lots more work to do in that. So I really appreciate your comments. So I'm going to, unless we have Alan or anybody Howard, I just want to thank all of you for being here. I want to thank Chief Campbell, who had to leave, but it was really fabulous to have an elected chief of the Squamish Nation come and open this. I see it as a little bit of a sign that our needle is, moving up around the work we're doing around reconciliation. We really are aware that there are many other communities in our health authority that we need to address, and we're really trying to focus on those issues. Lots of really great opportunities ahead, and I really appreciate all of your commitment and interest. And we'll see you again. Thank you so much.